Welcome, everyone, to our webinar on racism, COVID-19, and access to contraception and abortion services in America. I am Beth Rivin, President and CEO of Uplift International. For 23 years, Uplift International has been focused on creating solutions so all people have access to health services, including reproductive health. We believe that all people have the human right to health. And our Human Right to Family Planning Initiative, as we say HR2FP initiative, claims that every individual has a human right to decide if and when to be pregnant, no matter where they live. I want to thank the ACLU of Washington for their support of this event that will expose the intersectionality of socio-political issues and health. Civil rights are linked to health rights, and health rights are reproductive rights. They are women's rights, and they are foremost human rights. The theme of racism, COVID-19, and access to contraception and abortion services in America is so broad and yet so interconnected. We are living through unprecedented times and experiencing multiple socio-political crises at the same time. Black Lives Matter movement and the reawakening of racism. COVID-19 pandemic, with the current president flaunting public health experts. The passing of Supreme Court Justice Ruth Bader Ginsburg. And at the same time, the current Senate confirmation hearings of Judge Amy Coney Barrett. Make no mistake, this is a watershed moment in history. All of these interconnected crises affect access to health, including reproductive health services. Contraception and abortion services are essential health services, and they have been impacted by these interlinked, threatening social and health situations in the U.S. This impact has been felt disproportionately and unfairly by Black, brown, disabled, immigrant, and poor Americans. Why is this happening, and how is this happening? What can be done about the situation? This is what we will be talking about during the webinar. Our discussion is timely. At this very moment, the Senate is conducting a hearing on the nomination of Judge Amy Coney Barrett for confirmation to the U.S. Supreme Court. What is at stake is access to health care in general and access to safe and affordable reproductive health services in particular. We have seen the polls. We know what Americans want. We are in the middle of a pandemic, and the number one issue is health care. And reproductive health care is essential health care. According to last week's Washington Poll ABC poll, a clear majority, 62%, believe that the Supreme Court should uphold the decision that guarantees a woman's right to abortion, the 1973 landmark decision of Roe v. Wade, while 24% say it should be overturned and a sizable 14% have no opinion. I can't imagine no opinion. We have an exciting group of speakers today. We will be hearing about what is actually happening in Indiana and Kentucky, where unprecedented restrictions have made it increasingly difficult for women and girls to access reproductive health care. We will also be hearing about the role of the Supreme Court, RBG's legacy, and what is at risk. Additionally, we will hear about the Hyde Amendment, other legal restrictions, and criminalizing self-managed abortion. Other speakers will address reproductive health care as an outgrowth of the country's origins and the unique Native American perspective on reproductive justice. Before we begin our panel, I would like to introduce a special presentation by Congresswoman Pramila Jayapal, who will not be able to be here live today, unfortunately. However, she has pre-recorded her comments.
Hello, I'm Congresswoman Pramila Jayapal, and I'm proud to represent Washington State's 7th Congressional District in the U.S. House of Representatives. I'm honored to address your conference today, and I want to thank everyone at Uplift International for all the work you do. I know we would all much rather be in person, but I'm so glad we're gathering virtually anyway, because it has never been more critical to lift up the need for abortion access, reproductive justice, and the notion that all should have a human right to family planning. I don't have to tell you why. We have lived through 4 years of an administration that has threatened reproductive rights at every turn, most dangerously by appointing anti-choice judges to the federal bench, including the Supreme Court, and encouraging and supporting oppressive and unconstitutional abortion decisions at the state level. And right now, in the midst of a global economic and public health crisis, it has never been more clear that reproductive justice and reproductive rights are not just women's issues and not even just health issues. They are economic issues and racial justice issues too. Not only are women, and especially women of color, more likely to work in jobs deemed essential, putting them at greater risk of contracting COVID, many states have attempted to deem abortion access non-essential. That is simply untrue, unconstitutional, and we must fight back with everything we've got. Reproductive rights are human rights. 1 in 4 women have had an abortion. And as some of you may know, I am one of them. So I know that having an abortion is a deeply personal choice. And I know that every person, regardless of income or zip code, should have the right to make that decision for themselves. Because let's be very clear, attempts to erode abortion rights, reproductive choice, and restrict access to contraception and abortion services are cruel and unjust. They punish women and pregnant people, and they disproportionately harm low-income people and people of color. And they are, above all, unconstitutional, plain and simple. In Congress, I'm working hard to remove barriers to care, now in a global pandemic and during all times in the future. I'm also defending reproductive rights and standing up for a holistic understanding of reproductive justice. I helped to introduce the Women's Health Protection Act last year, which would put in place a safeguard against abortion bans and medically unnecessary restrictions, like those attempted in Louisiana and Texas. I also believe we have to repeal the Hyde Amendment, and I'm proud to say that my Medicare for All Act, introduced in the House in 2019, does exactly that. It would also make sure that affordable, accessible, and comprehensive reproductive care is guaranteed for everyone in every state, and that it includes specific non-discrimination protections so that no employer or provider can opt out of providing critical reproductive care or services. Reproductive decisions are personal ones that belong to women and pregnant people. They should never be at the whims of employers, states, Congress, or the courts. We also have to reverse the Trump administration's gag rule, increase Title X funding for women's health care, codify Roe v. Wade in statute once and for all, and fight back against judicial nominees who threaten reproductive justice. At Uplift International, you know all of this. That's why you've made it part of your mission to expand access to reproductive services and education all over the world, often in places where that information can be incredibly hard to come by for so many. As someone who spent years working in international development, I want to thank you and remind you how very much we need your work. I know the battle to protect reproductive rights may feel exhausting, but we must never stop. We have the power to make this right, and I will be with you every step of the way.
So thank you, Congresswoman Pramila Jayapal. I am delighted to introduce our next speaker and the moderator of our panel, Michele Storms. Michele.
Thank you so much, Beth. Good afternoon, everyone. My name is Michele Storms. My pronouns are she, her, hers. And I'm coming to you from Seattle, Washington, the land of the Duwamish people and the Coast Salish people. I'm honored to speak to you a little bit and moderate this panel of brilliant humans dedicated to access to reproductive freedom and dedicated to equity and justice for all. The ACLU of Washington, of course, shares these convictions, and as a nonpartisan organization that has been around for 100 years, will always fight for democracy and freedom. Access to health care is an important issue for us. Through litigation, legislation, and activist mobilization, we've dedicated much effort to ensuring people's access to abortion services, gender-affirming care, end-of-life service, and more. As Beth has pointed out to you, we are facing multiple pandemics in this moment. And as the title of this event indicates, we've got COVID, racism, and restrictions on reproductive rights, amongst other woes. Now, COVID-19 is devastating communities, especially the communities of Black, Indigenous, people of color, people of low income, our elders, those with other health conditions. Structural and institutional racism, unfortunately, is also alive and well in the U.S., and it's baked into the very origins of our country. Our country was founded on an attempted genocide of Indigenous people. And one day after Indigenous Peoples Day that we recognize here, we have to remember that every day Indigenous people are still here and still in need of restoration of their rights. Our country was also built on the forced labor of Africans, and also in its origins, it subjugated the rights of women and children who were considered chattel under law for decades. So we're still fighting back against those statuses because generations of marginalization and vulnerability do not disappear in a moment. We have to fight particularly for those communities experiencing the deepest and cruelest forms of discrimination and indignity. And in so doing, we actually make our country better, our Constitution, and our democracy valid for everyone. So when we acknowledge that racial disparities and gender discrimination and these concerns about our rights aren't accidents, they actually flow from the legacy of racism and patriarchy in which this country is founded, then we can see the intersections and we can begin to make positive change across the full spectrum of human rights and all of our humanity and our freedom to be who we are. So Beth mentioned police brutality, and right now that is absolutely one of the ways in which state violence harms, especially Black, Indigenous, and people of color, people with disabilities. Recent murders of Black people by police have taken us over the edge and brought people to the streets to express their constitutional right to protest. And yet even in the face of folks exercising their rights, police brutality has been enacted against protesters. We're still in shock that the grand jury in Kentucky failed to hold law enforcement accountable for the senseless murder of Breonna Taylor, a Black woman whose only crime was sleeping in her own bed. So when we look at the right to contraception and abortion and the full range of reproductive care, we're talking about what it means to allow some people to control the bodies of others. So I'm going to make this connection, right? So in the policing conversation, I've heard some say that some people get to have public safety as a commodity. Literally, it is something they own. And that those who claim this privilege of public safety as a commodity have it at the expense of others who are not entitled to the same benefit. Public safety belongs in our current culture and context to white people, often at the expense of Black, Indigenous, and people of color. And it's a truth that must be changed. So you can look at reproductive health similarly. Some seek to own the rights to control the bodies of others. And again, this most harms the safety and health of those who have been made vulnerable by generations of oppression, whether we're talking women, women of color, trans and non-binary persons, people of low income. So what is it that those who oppose reproductive health get to own at the expense of women and marginalized identities that do not get the benefit of reproductive autonomy? It's the freedom to the right to their own bodies. So reproductive oppression isn't just restrictions on abortion and contraception. We know this, right? It's sexual assault, forced sterilization, medical testing. It's about barriers to becoming pregnant and having healthy pregnancies and births. And it's about having a safe environment in which to raise children to adulthood. So when we look to reproductive health access, its history and where we are today, we see the interconnectedness of these ills. Black people have been subject to coercive reproductive control since arriving in the United States. During the times of bondage, Black women had the status of property subject to sexual and reproductive exploitation. The 19th century prohibitions on birth control and the criminalization of abortion had racial motivations arising out of Anglo-Saxon Protestant fears of being overtaken demographically by non-white people. forced sterilization of people of color through both overt and subtle means is also a part of America's history, and it was a practice explicitly condoned throughout much of the 20th century into the 1970s. And of course, the recent, not recent, but the long generations of police killings lay stark the reality that many people of color do not have safe environments in which to become pregnant and raise children. Of course, we also know that the reproductive health movement has played its part in enabling this. And while in 1994, a group of Black women founded the reproductive justice movement to defend the needs of women of color and other marginalized individuals, including trans and non-binary people, many reproductive health organizations, and even the ACLU ultimately didn't fall into step. But the reproductive health movement has largely continued to adopt a framework that ignores and minimizes the racism implicit in America's history and in the anti-choice movement. So, systemic racism is seen as our police system and in our healthcare system. Again, the restrictions on abortion and contraception fall heavily on communities of color. And so here are just a couple of other factoids as we go on, right? So Indigenous people and people of color are more likely to be uninsured and face challenges in accessing care, including reproductive health care, have higher rates of certain underlying and untreated conditions which impact reproductive health than non-Hispanic whites. People of color experience some of the highest rates of cervical cancer, unintended pregnancy, maternal mortality, and sexually transmitted infections in the country. And amongst the American Indian and Alaska Native and Black women populations, the likelihood to die from a pregnancy-related cause is 2 to 3 times as likely as for white women. Breast cancer death in the U.S. is 40% higher for Black women. As organizations and advocates and as individuals, we can and must do better. And I hope we can think about the history and what has brought us here, acknowledge the communities most burdened when reproductive health care is restricted, and work together to address systemic racism in all the ways that it shows up. And one more thing. I don't wish to ignore that we are currently in the midst of these Senate hearings to appoint a new Supreme Court justice. We lost Justice Ginsburg, who was a champion for women's rights, and the president seeks to confirm a new justice who has been openly opposed to abortion. Some of our speakers will have more to say about that shortly. So again, I'm thrilled to have us hear from our brilliant speakers and for us to be in a conversation together after they each make a few opening remarks. Our first speaker is LaKimba DeSadier.
Thank you, Michele, and thank you, Uplift International, for this moment. Again, my name is LaKimba DeSadier. My pronouns are she and her, and I'm excited about the dialogue that we will be involved in and the information for the panel. Currently, with 15 clinics in the state of Indiana, Planned Parenthood, Indiana and Kentucky, PINK, brings 85 years of support and experience by providing reproductive health care and information in our communities. Research showed that since 2019, PINK has serviced nearly 35,000 unduplicated patients in Indiana. 35,000 unduplicated. The majority of that care was preventative care, for example, breast examinations, cervical screenings, birth control, and STI testing and treatment. When someone speaks about Planned Parenthood, polling shows that Planned Parenthood is rated as one of the most trusted names across the country. Confidential, preventative, informative, and caring for everyone. Planned Parenthood believes that all people have the right to health care. Like other red states, Indiana has become a ground zero for anti-reproductive rights legislation. 70% of women that live here in Indiana, counties do not provide a abortion provider. Let's just stay here for just a second. As mentioned earlier, as our U.S. Senate meets to vote for the nominee of our next Supreme Court Justice, and if Judge Amy Coney Barrett is confirmed, she will end abortion access to Indiana and dozens of other states across this country. Let's remember what Trump promised. He was going to appoint judges who did the right thing when it came to the Affordable Care Act, ACA. Trump believes that Barrett fits that bill. When we talk about the outbreak and how it's affected us, the outbreak of the coronavirus has been exposed to be true, especially when it comes to people, places, and communities of color. The economic inequality and structural racism and public health failures have now collided and resulted in higher infection and health and death rates when it comes to Black Hoosiers here in Indiana. Indiana ranks 48th in this nation when it comes to maternal mortality. And when you start breaking down the numbers, maternal mortality affects African Americans more. Maternal mortality is killing Black women in Indiana 2.5 times the national average. And infant mortality is nearly 2 times higher for Black infants than for white infants in Indiana. Why? STI rates? Yes, they have been growing across the state for all population. But Black Hoosiers are expecting and experiencing dramatically disproportionate infection rates. It's contradicting everything that they're saying. Right now, Black Hoosiers are contracting chlamydia at 6.7 times and gonorrhea at 11.4 times the rate of white Hoosiers. When we start talking about COVID, the infections in Indianapolis, the Black people in Indianapolis are nearly 3 times of white people. These numbers are absolutely unacceptable. And we must take steps to dismantle this systematic racism and bias. Only then will our communities meaningfully achieve equitable reproductive freedom. When we talk about access to abortion care, access to abortion care is an issue here in Indiana, and it started a long time ago. As I stated earlier, 70% of women that live in a county here in Indiana are without abortion services. Indiana has passed more restrictions. We have passed more restrictions than any state in this nation aside from Louisiana. Our Indiana state lawmakers have passed 63 abortion restrictions into law between 1973 and 2019. Just last month, we marked 44 years of Hyde Amendment. And I know that one of the panelists will walk through that, but I want to share what the Hyde Amendment was. It was created to prey on people with low income, people of color, and people who use Medicaid to ensure that they can meet their needs, their affordable needs when it comes to care. So this means for states like Indiana, most people, low income, people of color on Medicaid do not have abortion coverage. The lack of coverage means high pocket costs and now delayed care, which is both harmful to the patient's health and it makes care more expensive. Due to this structural and institutional racism and discrimination, BIPOC, Black, Indigenous people of color, are more likely dealing with income inequality and therefore are more likely to be covered by Medicaid. So the Hyde Amendment disproportionately harms the health and economic security of BIPOC communities. Indiana abortion lawmakers continue to place barriers that limit the access to abortion care. For example, a patient must receive state-directed counseling that includes information designed to discourage the patient from having an abortion, and then wait 18 hours before the procedure is provided. Counseling must be provided in person and must take place before the 18-hour wait begins. So that means patients must take 2 trips to the facility. Another example, a patient must undergo an ultrasound before obtaining an abortion. And then the provider must offer the patient the option to view the image. Indiana reproductive freedom is constantly under attack. Title 10 was legally designed to prioritize the needs of low-income families and uninsured people, including those who are not eligible for Medicaid, who might otherwise have access and need access to these services. These services are provided to low-income and uninsured individuals at reduced or no cost. Planned Parenthood was forced to withdraw from the Title X program in 2019 because we did not adhere or agree with the gag rule imposed by the Trump administration. For those Title X providers that stayed in the program, now they are legally prohibited to tell patients medically accurate, comprehensive information about their body and their pregnancy options. Trump's domestic gag rule has left nearly 6,000 patients here in Indiana without access to care. And our current governor has done nothing to fill that gap. Medicaid attacks. Well, our former Indiana governor and current Vice President Mike Pence has left a legacy of barriers in Medicaid through Health Indiana program, HIP. HIP exposes cost sharing and work requirements on the lowest income Hoosiers. And our current governor, Governor Holcomb, has done nothing but built on that platform. Holcomb's version of this program requires Hoosiers to contribute more to their Medicaid coverage and could cause more than 87,000 Hoosiers to lose their health care coverage. Okay, so let's talk numbers. So approximately 30% Black women and 24% Latino women aging from 15 to 44 are enrolled in Medicaid. Now that's compared to 14% white women. And among Americans under the age of 65 who receive Medicaid, nearly 11 million are Black and 8 million are Latino. This number shows us that Medicaid attacks are real, and they have been disproportionately impacting Black and Latino communities. We talked about the ACA and SCOTUS. Healthcare for people, particularly women, with pre-existing conditions, it's on the line. Right now, 3 million Hoosiers can access preventative services at no cost because of the ACA. If the ACA is eliminated, people in Indiana may have to pay more into preventative services, something like flu shots, mammograms, cancer screenings. And let me be clear, it would disproportionately harm BIPOC communities more than any other community, which means dramatic health care disparities. Our nation is facing a dual public health crisis of systematic racism and COVID-19 pandemic. The question is, what are you going to do? You should be doing something. I'd like to end my conversation with one of my favorite quotes from the late Congresswoman Shirley Chisholm. Service is the rent you pay for the room on this earth.
Thank you, LaKimba. Mi taya kapi chante washte na pe chayuza pe. Taya wanchian kapi Camie machiapi. Sisseton-Wahpeton Dakota wiyan hemacha Seattle ekthawati. Hello, my relatives. In my tribe, we greet everyone as relatives, as cousins, aunts, and uncles. I greet you with open hands and an open heart. It's good to see you all today. My name is Camie Goldhammer, and I'm a Sisseton-Wahpeton woman living in the occupied territories of the Duwamish people. So I'm really grateful to talk a little bit about the work that I do in my community, particularly around supporting Indigenous people in receiving and being cared for after the termination of pregnancies. So I wanted to spend a little bit of time talking about the Native community. I'll speak a little bit specifically around the community here in Seattle, our urban Indigenous community, but also a lot of this is relevant to Indigenous people. And as our other speakers will share, it is relevant to many of our BIPOC community members as well. One of the things that I think is really important to recognize when talking about reproductive justice and reproductive rights, particularly for folks that identify as Native. And I just want to clarify a little bit around the language that I use. I will often refer to when I'm speaking generally about Native people, particularly those that are from the continental United States or North America, so we call it Turtle Island. If I'm speaking generally, I will use terms like Native American, Native, Indigenous. I just want to clarify that because I know that we all are used to different terms. And yeah, so I'll be speaking kind of more generally, which is why I'm going to be using terms like Native or Native American versus using like a specific group, like I am a Dakota person, so I speak as a Dakota person. So yeah, so when we talk about reproductive justice and reproductive rights in Indigenous or Native communities, I think it's really important to recognize that prior to colonization, we know in our communities that people with a uterus always controlled their fertility. We have no evidence to suggest that our communities prior to colonization saw things like ending or terminating a pregnancy before it was full term as taboo or something that was deemed illegal, right? Or something that you couldn't do in a community. We know that we had medicine people who took care of us during that time, and there would be a multitude of reasons as to why a pregnancy wouldn't be wanted, right? Whether that is the person's personal choice at the time, or it was not good for the entire community to bring a baby into the world at that time, right? There was lots of different reasons, and the community cared for that person in their own ways when it came to ending that pregnancy. Like I said, we had medicine people, which would, today we would call them midwives, or those caretakers that cared for people that were pregnant. Those were also the people that traditionally cared for folks at the end of life, right? We had medicine people that welcomed new life, but they were also the ones that made sure that when life was ending, that person was being cared for in a good way and sent off in a good way. And so with, I don't need to give a full history lesson about colonization, but we know that Christianity and, colonization of the indigenous people of Turtle Island go hand in hand, right? Prior to colonization, we had no evidence that terminating a pregnancy was seen as wrong. We also had no evidence to suggest that we hurt our children, right? Things like corporal punishment, that kind of stuff, those were all learned, right? Those were all learned through various forms of assimilation that was systematically implemented by the U.S. government in partnership with the Catholic Church. And I think that it's really important. I mean, even when LaKimba was talking about the current SCOTUS nominee. And, I think many of us are aware of her faith, but I just, was thinking about the role of the Catholic Church in the colonization of indigenous people. And, it brings up some stuff for me, I'll be honest, like it brings up a lot. It brings up, a lot of trauma that is deep down in my genes, right? That's been passed down from generation to generation through my ancestors. And it's really, really hard. I think that it's also important to recognize, because I will say in large part, today's Native people, a majority would probably identify as pro-life, right? Or anti-abortion. That very much could be because they hold religious beliefs that dictate those types of beliefs, right? But I think it's also really important to acknowledge the massive loss of life of indigenous people as a result of colonization, right? It is estimated that there was approximately anywhere from 25 million to 250 million indigenous people on Turtle Island prior to first contact, right? And it is estimated that at our low, there was anywhere between 250,000 and 2.5 million Indigenous people, right? There are currently, as according to the last census, about 4.1 million people in the United States that identify as Indigenous, okay, or identify as Native. And so that is a huge loss of life over the last several, 100 years. And I think that that's a really important thing to talk about when we're talking about providing culturally relevant care, when we're talking about meeting Indigenous people where they're at, that there is a desire and a belief that we need to have more Native babies, right? And that terminating the pregnancy of a Native baby is somehow, sometimes not seen as a positive thing, even though that person might identify themselves as pro-choice, right? And so I just want to talk, make it clear that this is very complicated, right? It's not this black or white issue when it comes to Indigenous people. For me and the work that I do at Daybreak Star Doulas, we are a full spectrum doula program. A doula is someone that provides emotional, spiritual, physical, and mental support to a pregnant person. And full spectrum means that we provide that support to someone regardless of the outcome of their pregnancy until the end of their pregnancy, whether that happens earlier on and not with doesn't end with the birth of a child, right? Or we would certainly support a person through their labor and delivery and parenting their baby as well. Okay, so that's what full spectrum means in the context of doula work. When I was creating our doula program several years ago, it was very, very, very important to me that we would be a full spectrum doula program. I talk a lot about decolonizing reproductive health, decolonizing pregnancy, decolonizing Indigenous breastfeeding, right? All of these different terms, but it really boils down to decolonizing doula work, right? And what it is that we do. And so for me, there was no other option but to support people who were terminating their pregnancies, right? We cared for them traditionally in the same way we would care for anybody else that was pregnant and is no longer pregnant, right? We care for a person that terminates a pregnancy postpartum in the same way we would care for someone that is postpartum but is caring for a child, right? We still love on that person. We give them medicines, which is a really important piece of it because we think of medicines have a very high regard in our community. They are it's an important gift to be able to take medicines from our earth, right? And our elders tell us what to do with those medicines. And so being able to provide a person who just terminated a pregnancy with medicines to care for their body, to heal, right? And then also to have someone there that can talk with them about what they're going through. Maybe we do ceremony with them. Maybe we find an elder that they can talk to. It's really up to that person and what they need. And we will do that until they no longer feel the need for that care, right? And it's been incredible work. I, as the manager of the program, care for a lot of our parents that are terminating pregnancies. I will attend their abortions with them as a doula, and care for them during that time, right? Because, oftentimes it's not a black or white issue for these families, right, that are choosing abortions. There is grief involved. There is loss involved. There is, pain and trauma. And we need to love them through that and honor those feelings, right? Because at the end, we want a healthy, whole person. And so being able to care for them in that way is really, really important. And so, I also, want to talk a little bit about the epidemic of missing and murdered Indigenous women in our community. I think all of the speakers are going to address different aspects, and then of course we'll have time to talk as a panel. But as many of you know, we have an epidemic violence against women as a whole in our country and as a community. And when we speak specifically about Indigenous people, it is different. We have jurisdiction issues. We have policing issues where, a missing Indigenous person is not treated the same as a missing white girl, right? We've seen this in many of our other communities as well. We also, for a lot of us working in the birth community and in the Native community, we have been having lots of conversations about how many of the missing and murdered Indigenous women out there were pregnant or were postpartum, right? What was going on during that time? We know that violence against pregnant people, that they're, more at risk of being killed, and being, victims of domestic violence. And I think that that's an important thing that we need to discuss in the context of missing and murdered Indigenous women. And then lastly, thinking about the Hyde Amendment, which I think we might get to talk a little bit more about. LaKimba gave a great introduction into it. This is something that's very much on our mind. We know it disproportionately affects Indigenous people. For us, our ancestors signed treaties that guaranteed our health care by the U.S. government. So almost every single Native person who's enrolled in their tribe in this country receives their health care from the federal government, which means that we are not able to get or receive an abortion using our own health insurance, right? And again, that is a treaty that our ancestors signed. They signed treaties. They signed away their land, their natural resources, knowing that the U.S. government was going to uphold that treaty and provide us with health care and provide us with education. And that is simply not at all what has happened over the last several hundred years, right? But thinking even a little bit more closely around the Hyde Amendment, and if for some reason, around the SCOTUS Supreme Court Justice nomination, if Roe v. Wade is overturned at the federal level and abortion rights go down to the state, this will disproportionately affect Indigenous people. There are 403 Indian reservations in the United States, and 2/3 of those, it's like 221 of those reservations are in red states. Right? They're in rural areas. And so thinking about where we can go to get abortions, how far we need to travel, a majority of Indigenous women will not be able to access an abortion in their state. Okay. And that's something that, will be an added barrier to the already huge barrier that the Hyde Amendment, has. So I think with that, I will pause and let our next speaker go, and I'm looking forward to the panel. Thank you for listening.
Thank you so much for that, Camie, and hopefully some of the things that I am planning on speaking about will also tie in some of the pieces that you spoke about, that LaKimba spoke about, and that Michele brought us into the space with. So I am going to start my part of the talk by kind of creating the container that I'm talking in today. Partly because if I don't do that, I will be in space and I can talk ad nauseum. It is what lawyers do. It is one of the worst things about us, right? So one of the things that I kind of want to set the container, one of the pieces of it, is the idea that reproductive justice is racial justice and vice versa, right? And at work, we refer to it as RJ squared. And reproductive justice, as Michele mentioned earlier, is this framework that was created by Black women in Chicago, and that was created as a response to the impact that laws and policies about reproduction in general were having on women of color and on Black women specifically. It's a human rights framework that attempts to draw attention to and dismantle the legacy of these racialized white supremacist laws that we have about reproduction and who gets to own their own bodies, right? And RJ asked the question and makes the demand, quite frankly, how can we self-determine if, when, and how we sustain and build families with dignity, right? Like that dignity aspect is particularly important because it's not just about abortion and it's not just about birth. It's this very open, full spectrum idea of what does family and community really look like and how can we actually have that look the way we imagine it, right? How can we be emergent with our thinking? And reproductive justice demands racial justice, right? Because once we realize that communities of color are over-policed and over-regulated, right? Those regulations that are not necessarily criminal laws, but regulations that must be followed that exist in certain communities that do not in others, particularly existing in communities of color. When we realize and understand that family regulation systems, and after listening to a very spirited talk by Dorothy Roberts, I've stopped using the terminology child welfare systems because the reality is it's not about the best welfare of the child. Because if it was, it would be applied the same across the board. But what we're seeing, it's about what families and what communities must follow certain regulations, right? The way that families on reservations are regulated by systems is certainly different than how white families living in suburbs are regulated. The way that families living in the hood that are living in the projects are regulated is certainly different across just a few steps in those same cities and towns. So what we realize when we look at how these systems are affecting folks' lives, we realize this interconnectedness that we can't leave anything behind when we're talking about communities and family, right? That reproductive justice is not just about birth and abortion. And with that container, I want to talk about this term that I hear all the time, this fear that certain folks are starting to tap dance towards, this idea of like this post-Roe reality. What will we do if Roe falls and we no longer have the protections of Roe? And I understand it. I understand being scared for the first time, right? This idea of like, now I am in fear because I feel very affected about the possibilities. But here's the kind of offsetting reality that might be upsetting to some folks. A lot of people have been living in this post-Roe world. And one example that I like to give, a lot of folks have been talking about the Hyde Amendment, and not so much about Harris v. McRae, but Harris is also incredibly important. After the holding in Roe v. Wade in 1973, the congressman from Illinois, Mr. Hyde, brought up what we now kind of refer to as the Hyde Amendment, and it was the demand that federal funds, particularly Medicaid, cannot be used to cover abortions. When it was first introduced in 76, it even barred the use of those funds for abortions, even in the case of incest and rape. And shortly thereafter, there was an amendment to the Hyde Amendment, which allowed funds to be used for those purposes. But I'll just add as an asterisk that that's not an actual real reality for folks even after they have experienced sexual violence, because that requires them to interact with certain systems. And it has specific requirements about how do you prove in advance that you were actually harmed sexually in order to be granted your abortion in time within the laws that exist in your state to be able to access that kind of clinical care. So what Hyde did was kind of block access for, at the time, hundreds of thousands of people. You heard Camie talk about how that affected certain communities that are indigenous to North America, particularly in the United States, right? And it also widely affected folks that were lower income and were getting their insurance through Medicaid and were relying on that. It was like, yay, Roe v. Wade. And then shortly thereafter, 3 years later, actually accessing that right wasn't real. It wasn't tangible any longer. And the case went up to the Supreme Court, this kind of through-line SCOTUS, right, in 1980. And that case was Harris v. McRae. And it was asking the court to uphold an injunction saying that there was an injunction shortly thereafter, after the Hyde Amendment was passed, saying that, hey, court, don't let them do this. And the court came back and their holding was like, no, we are going to let the Hyde Amendment continue to exist. They found in the actual decision, it found that the funding restrictions don't impinge on the due process clause, and the legislation did not operate to the detriment of the suspect class. Whoa. Right? So one of my favorite dissents, because Justice Marshall wrote such rousing dissents, some of the most empathetic, good law exist in dissents, as we're seeing from the history of Justice Marshall and also to our current reality of Justice Sotomayor. And Justice Marshall calls out exactly what Harris actually does, right? What all of this doublespeak that Blackburn and all of these folks are saying. He says in his dissent, quote, "The court's opinion studiously avoids recognizing the undeniable fact that for women eligible for Medicaid, poor women, denial of Medicaid-funded abortion is equivalent to the denial of a legal abortion altogether." So he calls it out. He's like, what you're really saying is that poor women aren't allowed to have abortion. You're foreclosing them from that right. And he goes further and points out how this harms indigenous communities and particularly women of color as a whole, right? Because he's talking about, look at these specific groups of folks that you are harming. And when we think about kind of in the beginning, abortion does not start with Roe v. Wade. A lot of people are living in this post-Roe reality, right? Folks that are not able to access clinical abortion the way they want to, because we've seen that abortion has been dying this death of 1,000 cuts, as we say it, right? Every single year, there's a new regulation, there's a new trap law that's enacted, moving folks further and further away from being able to access the care that they want. And it shows you that SCOTUS, though they are not granting folks this full picture of what they should have, does have a real place in how this abortion jurisprudence allows folks to have access. So that kind of gets me into talking to Ruth Bader Ginsburg, who we know has recently passed away. So Ruth Bader Ginsburg's legacy on abortion and reproductive rights as a whole has been kind of the definition of standing both feet in, right? At her confirmation hearing back in 1983, correct me somebody if I'm wrong, she said that the right to abortion was the question about ending your own pregnancy, about being able to make that choice. Choice was something central to a woman's life, to her dignity. It's a decision she must make for herself. When government controls that decision for her, she's being treated as less than a fully adult human responsible for her own choices, right? She was recognizing this idea that taking away choice, and at the time using incredibly gendered language, because what we do know is not only women get pregnant, not only women have babies, it's folks with uteruses, folks that have the ability to get pregnant, right? But what she's pointing out is this idea of separating someone from being able to make their full choices about their own bodily autonomy because of their ability to do one function, and that is get pregnant, is taking away their full personhood, right? You're relegating a whole group of people to second-class citizenship. And also going into her legacy, as far as the decisions she's had, her concurring opinion most recently in 2016 in Hellerstedt, she interrogates these trap laws, which are targeted restrictions against abortion providers, and she calls them an undue burden to the right to abortion, right? But when you're talking about Ruth Bader Ginsburg, you have to look at the full holistic view of what her legacy truly is, right? And she has done wondrous things, has spoken up for so many women's rights, how the fact that like the equal pay being at the forefront due to some of the work that she's done, her willingness and her ability to speak up for women has been something that should be absolutely lauded. However, she also has passed the buck on issues where she had an opportunity to stand in, and she also has done harm in her decisions, right? I was attempting to pull cases before we got together for our talk, but it felt a little fruitless, mostly because a lot of years on the court. Okay, I'm running out of time, but I'll just try to get to it. Her decisions on the rights and prerogatives of indigenous communities has been incredibly lacking. Most recently in Utah v. Strieff, where she basically punted on the opportunity to concur with Justice Sotomayor in full and basically decided that she didn't want to sign on to the section that basically called out systemic racism in policing, right? And I really want to get into self-managed abortion. So hopefully I know we're kind of cutting close on time, but I really want to, just because when we're talking about access to abortion, folks also need to talk about self-managed abortion, because not everyone does a clinical abortion, not only because they can't access it, but quite frankly, because some folks don't want to. Sometimes they have really complicated histories and relationships with traditional medical care. Sometimes the clinics are too far away. There are too many protesters outside of their clinic. They want to do it through traditional means in their own culture. They want to do it at home with family and friends, right? And also the advent of medication abortion has made doing your own abortion so much more accessible to do in a safe way than ever before. Folks are using misoprostol and mifepristone and are accessing unadulterated misoprostol and mifepristone even outside of the clinical care to be able to self-manage their abortions. And these pills have been approved by the FDA for over 20 years. And most recently, Plan C had a study where they found that the pills ordered online are largely identical and unadulterated in comparison to pills that folks get from providers. So I don't want to kind of miss out on the opportunity to do panelist questions. So hopefully I'll get a chance to talk about criminalization of self-managed abortion as yet another barrier to folks accessing their right. But I don't want to cut into too much time, so I'll cut myself off here.
Thank you so much, Yveka, and thank you, all of you. And all of you are doing such critical work in very different spheres, and what you were sharing was so important, we didn't want to stop. So we're going to go just a little bit over. If people will bear with us, we'll just go maybe about 10 minutes over. And here's where I want to come in, and so I'm going to let you think about this, because you may get to answer one question, so you think about answer this as you will, right? Everybody, each of you, spoke about disparities that are experienced by women of color, people with low income, folks in rural areas, tribal lands, etc. And that is about everything from infant and maternal mortality to the ability to access healthcare, including reproductive healthcare. And so obviously this needs to change, but it's a long-standing problem that's been out there for a while. So I would really love for each of you to take on a little bit more directly what it is either that you and your organization are doing to try to break down those barriers, or what you would hope that we as a movement, as many people, as individuals, as lawmakers, or whoever can do. So we need some champions for getting rid of these disparities. And so address that, really however you see fit.
So here in my role, my encouragement is about understanding who, as you said, are your leaders, who are your policymakers. And what our encouragement is that all politics are local. So everyone in their state should be involved in this coming election. And I'm not talking about just the presidential race. I think you should be researching on federal and state as well. I'm talking from the governor to the district attorney, to the AG, to your state and Senate representatives, because they are the ones that are going to be making these decisions. Whatever happens on the federal level and what happens in the Supreme Court, what I'm understanding, if the Trump administration is moving forward, they're going to start moving this stuff down to the states. So you need to make sure you have champions there that are going to reflect not only your views, but your community's views. Because it can't just be an individual thought. It has to be a holistic part. And from that point, you make sure those champions are able to address racial inequality. They have to address that. And I love, Yveka, what you said. I've been saying this, you cannot talk about reproductive freedom without talking about racial freedom. And we have to address that. I'm going to pause and let the other panelists speak. Thank you.
Thank you so much, LaKimba. I love that. And given the season that we are in, fill out your census, fill out your ballot. Okay, Camie.
Yeah, I mean, it's a lot to take on, and thinking about what can we do. For me, in my organization, and what I often talk about, as someone who serves Indigenous people, is reminding us that we are sovereign people and that we get to determine what we want, and we can do what we want, and nobody can tell us otherwise, right? And that I think that that's something that's really important. I also think, when it comes to disparities and we have lots of conversations about this in the birth community as a whole, because of the atrocious maternal mortality rates of our country and the massive disparities that of Black and Indigenous people being having much higher rates than their white counterparts. That this really does boil down to community serving community, right? And looking at who, I think LaKimba, you mentioned this, like, who is doing this work, right? Who are you going to receive care from? Do they look like you? Do they care about you? Do they love you? Right? In the way that you should be loved in every way, right? And I think that that's one of the big issues when we talk about disparities, is that we often are forced to receive healthcare from people that don't love us, right? From people that have been systematically trained to kill us, right? And that's something that I think we need to address and have deep conversations about, right? And so I think maybe that's something. I'll just end there as well. and yeah.
Well, I love that. It's always appropriate for us to, like, we as human beings, we deserve to be loved, and we ought to treat each other with that love, right? And that care that leads then to that freedom and full expression of our rights and our identities. So, Yveka, you have the floor. You can weave in whatever you want to.
I've been trying to figure out how to do that, right? Like when you have the last piece that you're trying to put on the toast. So I want to talk about criminalization. And I think when one of the ways that we tie in a lot of the work that I do, work that's so close and near and dear to my heart, is this idea of who is closer to criminalization and further away. Because the idea of being criminalized, I think, is a veneer that's put on someone's identity. And it's a veneer that you can't really take off, regardless of what happens to an outcome of a case, right? Regardless of if you're ever arrested. The idea of being over-policed or scrutinized, it follows you around like a shadow. And when I'm talking about self-managed abortion, this idea of folks being able to take that aspect of their reproductive care into their own hands, making informed choices about what they want to do with their own bodies, and who is more likely to be criminalized, right? It's one of the things I talk about when it comes to self-managed abortion is the folks that are often getting in contact with the criminal legal system are being brought to the attention of the police by their healthcare providers. And I think we might have some healthcare providers kind of in the room listening, and there's no requirement for a healthcare provider to report someone to the police on the suspicion of self-managing their own abortion, right? There's no requirement. But there's this idea about stigma surrounding the abortion right as being something that's uniquely dangerous or uniquely bad, that there's almost this assumption, of course there would be a regulation that says I have to do this, right? And even the folks that might know that there's no regulation might look at someone that's experiencing a medical emergency, and because of their unconscious or sometimes conscious bias against poor people, Black people, Indigenous folks, against whoever it may be, feels the need to involve that criminalization system into that aspect of healthcare, because of those biases and how we think about what is bad and who is bad and what choices are good and bad, right? So if folks kind of leave out of here with one thing, what I want is for us to think more about how do we destigmatize reproductive care, the full spectrum of it. How do we talk about it? How do you talk to the young people in your life about periods? How do you talk to them about condoms, about accessing contraceptive care? Do you talk about it as if it's just a fact of life? How do you talk about abortion? Do you think abortion is this politicized thing that you can only talk about in groups where you know everybody agrees with you, right? Is this not dinner conversation? It's all dinner conversation. You don't say, oh, this is not the place for us to talk about colon cancer. You don't say that about any other aspect of healthcare except for abortion, right? Except for things that are dealing with bodies that have vaginas and uteruses. That's where that taboo is. So we organize lawyers oftentimes, but I think this is work for everyone to do. How do you talk about this stuff? Because the way you talk about it affects the public opinion. Public opinion affects policy. Policy affects criminalization, and that affects people getting put in cages for the choices they make about their bodies. So we all have work to do.
Thank you, Yveka. Yeah, I really love the way you talked about who's closest to criminalization, because this is a piece of it, right? And also talking about how we talk about these issues and where we do it freely, how we talk to our kids about it. That's all so powerful. I am so grateful to each of you for the work that you're doing and for the contribution that you made here in this discussion. Obviously, we could have spent another hour at it, but I know, I'm in Pacific time. It's only 5:25. Some of you it's 8:25. So I know you're about ready to be done. So thank you so much. I'm going to turn it over to Beth to close us out, but I do really just want to express appreciation for the panel and express appreciation for all the participants who have hung in here till the end, and for all the work also that you all do in the community. Beth?
Thank you, Michele, and thanks for your great moderating. This concludes our webinar today, and what a great session it was, including the excitement of a windstorm in Seattle. Thank you everyone who participated, and thank you to all of the outstanding speakers. Again, thanks Michele and everyone at the ACLU for your help in making this webinar happen today.